Thank you, Phil, very much for that introduction, and good afternoon, everybody, or good morning, depending where in the world you are. And it's a great pleasure to be giving the first of this webinar series for Trinity. So if I can have my first slide, what I'm going to do is to give you, first of all, a kind of broad overview of the problem of cancer presenting late, give you some idea of the size of that problem and a broad view, first of all, of how we might tackle that, what our aspirations are in the field. And then I'm going to spend most of the time talking about cancer of the esophagus in particular, which is the cancer that I work on, and the progress we've been making towards an early detection test. So, first of all, is early detection of cancer scientifically plausible? How could it be that we could really start to detect it before it's even apparent? And the rationale for this is that the life history of a cancer is actually a very long one. And for most of the time, the cancer is actually silent as it's starting to develop. So as a cell in a tissue starts to become abnormal with a mutation in its DNA, that cell may then start to expand and to cause a small abnormality or a lesion, which we might call hyperplasia, and it then can become pre-malignant. So if we were able to see it, there is a detectable abnormality, but at that point, the chances are that the individual would be completely unaware of the presence of this dysplasia because it wouldn't be causing any symptoms, and it could be very, very small, micrometers in size, and just sitting on the superficial layers of a tissue. So it's not disrupting the normal functioning or physiology of that tissue. And then gradually that dysplasia may become an in situ cancer and then locally invasive. And it's that locally invasive stage that we really clinically term a cancer. And that's often the point at which a patient will become aware it's there. It may cause a lump, or it may still be maybe internal, but they start to develop some symptoms which would at that point cause them to go to the GP. Now that whole process of becoming precancerous and malignant can actually take many years. It's estimated up to 10 years for most common epithelial cancers for that process to occur. So then that would give rise to the question, given it's such a long natural history, can we detect it earlier before it really starts causing a problem so that we can then intervene effectively and subvert it? It gets more complicated than that because some of these pre-malignant lesions or precancerous lesions actually may not go all the way through to become a cancerous lesion. They may remain rather indolent. And so the other big challenge in the field is to make sure that we don't start looking for things and causing a problem where actually it may never cause harm to an individual. So overdiagnosis and overtreatment is the other side of the coin, if you will, the yin and the yang of this challenge and opportunity that we have. Next slide. So let's think about how much of a difference early diagnosis would make if we really took this as a clinical strategy. These are statistics from Cancer Research UK. It's a summary for 8 different types of cancer combined. And clinically, we tend to group cancers according to their stage. And this is mainly done on imaging to see if there are any involvement of lymph nodes, for example. So if we take it that early stage diagnosis would generally be those cases we call stage 1 and stage 2, versus the late stage, stage 3 and stage 4, then survival overall is 3 times higher when cancer is diagnosed early. And so the government's Life Sciences Industrial Strategy just last year has put out a very ambitious goal of to try and increase the early stage of diagnosis from 50 to 75% by 2028. I think it's hard to kind of get one's head around these statistics. If I can have the next slide, please. And this was a puzzle I actually set for World Cancer Day last year, if any of you follow the puzzle on Radio 4, BBC Radio 4 today, early in the morning. And so the question is, how many cases of cancer would we actually, would this translate into with a new strategy? So if we look at the UK data, there are 363,000 new cases of cancer diagnosed every year in the UK. And 81% of those who were diagnosed early survived their cancer for at least 5 years after diagnosis, using those CRUK figures, compared with 26% diagnosed late. So the question I posed on this puzzle for today is, each year, how many more people will survive their cancer more than 5 years if we meet this new government target of increasing from 50 to 75% of cases diagnosed early? Next slide. And here is the answer. So the additional number of people who will be diagnosed, 25% times 363,000 is 90,750. Then using that figure, 81% would survive with the new target. If we look at how many more that would be compared to the 26% who would have survived anyway, that's 81% minus 26% times the 90,000 figure. That's 49,913 more patients surviving their cancer for 5 years in the UK, so nearly 50,000. And I think that just gives us an idea of the scale of what we're talking about. Next slide. So there are a number of considerations when we start to think of a test. What would an early detection test look like that could really have an impact and be feasible? And there are a number of aspects to this. There's the technology itself, of course. So, what would that technology be? How accurate is it? And also more on the logistical feasibility side of things. So what would the test entail? How much would it cost? What would the access to that diagnostic look like? Is this something that could be done in the community setting, or will you have to go to the hospital and so on? And these are some of the themes that will come through in my discussion of esophageal cancer, of things that we've really thought carefully about, to think not only about what is theoretically possible, but what is practically achievable in the NHS setting today. Next slide. So there are a number of different approaches one could take to making an early detection test. The first ideal might be to have a pan-cancer test. So this might be a test that you could apply to anybody in the population to ask the question, do they have a cancer somewhere? And ideally that test might also give you a clue as to where that has arisen. And there's a huge interest in this now, particularly using blood. And this has become possible to even contemplate, which really wouldn't have, we wouldn't even have been able to think about this 5 or 10 years ago. But because of our advances in sequencing DNA and the technologies around that, which are becoming increasingly sensitive, it is possible to detect DNA shed from a tumor into the blood, even before you know it's there. This is, as you can imagine, increasingly challenging the earlier you're trying to detect that cancer, so the smaller the lesion. Because obviously if there isn't a molecule of DNA in the aliquot of blood you take, then no matter how sensitive your technology, you won't find it. But this is the concept of blood biopsy, as it's sometimes called, or cell-free tumor DNA. And there are different sort of analytes in the blood that one can assess. And one of the tests out of Hopkins that has really helped sort of pave the way for this sort of technology is called CancerSeq, and that looks for a combination of mutations and proteins secreted into the blood. Next image, please. You can potentially look for early stages of cancer in any fluid, so blood is one. The other idea would be to detect this in the breath, a sort of breathalyzer for early cancer, with the idea that the volatile following metabolism through the liver of cancer cells could be detected as a sort of specific signature on the breath. And you may have heard anecdotal stories of dogs sniffing cancer, and you know, there are remarkable stories of dogs sort of sensing a difference in their owner's breath, and that being a signal that a cancer has developed. So can we then do that in a more systematic way through a breathalyzer, as shown here in this picture, and then using mass spectrometry, for example, to actually biochemically detect the volatile. This picture here is the technology from Alstone, which is a Cambridge spin-out. First, the technology was actually developed for detecting unexploded weapons and missiles and so on, and has now been extrapolated for use in medicine as well. Next slide. So here's something perhaps we're more familiar with, because this is an existing screening test. So this is a stool test for colon cancer. It's a kit that you do at home. And currently most of our screening tests are actually sent out to everybody above a certain age, for example, or it might be men versus women for breast cancer screening, but there's very little in terms of risk prediction to enrich the population to decide who you test for that cancer. So the screening tests that we currently have in the UK are for breast, for colon, for cervix. And they basically start at a given age, and it doesn't really take into account whether you have a family history or whether you are prone, for example, due to your lifestyle factors, smoking, drinking, that sort of thing. And there's a lot of interest at the moment by the National Screening Committee about whether we should be a little bit more targeted in how we apply screening tests. Next image. And so the idea comes about that as more and more we can understand what that personal risk profile might look like, we could then, rather than doing a kind of one-size-fits-all for screening, we could start to be rather more targeted. And there are significant advantages around this, particularly if you want to avoid the overdiagnosis that I mentioned before, and also in terms of the costs of introducing such a screening program. So this is an example of something called QCancer, which is a calculator that a GP can put in the characteristics of the individual and then determine, based on their risks, whether it would be appropriate at that time to offer such a screening test. Next slide. So what I want to move on to now is thinking about esophageal cancer, because this is a cancer that we don't have a current screening test for. And to my mind, it's a cancer that's very suitable to think about an early diagnostic strategy for reasons that I'll explain. So this schematic just shows you the esophagus in the center of the field there, going down towards the stomach. There are different types of disease that occur in the esophagus, two main cancer types, squamous cell carcinoma and adenocarcinoma. And the adenocarcinoma tends to occur towards the lower end of the esophagus at the junction with the stomach. And the main risk factor for this cancer type is reflux of acid and bile that can give heartburn symptoms. Next slide. So you might say, you know, why isn't esophageal cancer readily diagnosed? What do we currently do? Well, currently the gold standard for diagnosing a cancer of the esophagus is endoscopy. And when do we do endoscopy? Well, generally speaking, we'll do endoscopy when a patient has got swallowing difficulties, may have heartburn as well, losing weight, and that would trigger an urgent referral for an endoscopy. If a cancer is diagnosed, then usually by the time the patient's got symptoms, it's one of those more advanced cancers around stage 3 or 4. So the main risk factor is heartburn. And many of you have probably experienced heartburn, incredibly common symptom affecting around 10% of adults at some point in their lives. And the thought of trying to endoscope everybody with heartburn seems a rather unrealistic proposition. So endoscopy is a barrier. So in my thinking about this and trying to develop an early detection strategy, foremost in our minds was how we could get away from endoscopy and do something much more simple, straightforward, cost effective that you could do in an office setting at your GP's, for example, or in a pharmacy. Next slide. So, you know, how could we come up with a test that wasn't an endoscopy? Would we need to do an imaging test so you can visualize the esophagus to find the precancer? That would certainly be one option. And people are developing such sort of pill cameras, for example. But in my thinking about this, I felt that really if we could grab some cells from the esophagus without an endoscopy and then rely on pathological and molecular tests, then that would be the way to go, because we could keep the device very simple, but we could use sophistication in our lab analysis to really understand the stage that the cancers are on that process towards becoming an invasive cancer versus a pre-malignant disease. Next slide. So just to explain to you the technology, so comparing endoscopy with what we have come up with, which is this Cytosponge TFF3 test. So an endoscopy is carried out in a hospital setting. You need to lie down to have an endoscopy. You're generally sedated, or you may have an local anesthetic at the back of the throat. The imaging is fabulous now that we get. So we're able to see with exquisite detail as you go down towards the stomach any precancerous cells, which is called Barrett's esophagus, the pre-malignant condition to cancer of the esophagus. So you can visualize that and then take biopsies, and they're fine, a very small biopsy, which we take through the side channel of the endoscope, as you can see at the bottom of that image. And the test that we've developed, sort of by contrast, is a pill on a string that you give to the patient while they're sitting in an office setting. They don't need any sedation or local anesthetic spray. In fact, you want them to be able to just use their own swallowing mechanism to swallow the capsule, which will dissolve, and I'll show you that happening in a moment, to the give this sponge, which the nurse can then pull back and collect cells on its passage back out of the esophagus. Next slide. I thought you'd just be interested to see what endoscopy is like at the moment due to coronavirus. So the restrictions around endoscopy are quite severe, as you can see here, because it's an aerosol generating procedure. The mouth is open throughout the procedure with the mouth guard. You're putting water and air down the endoscope to clear the view. So you swish water down and then suck it out. And you can imagine that that does generate quite a bit of aerosol into the room. And so we're having to do proactive testing for coronavirus prior to the procedure, and or equip the personnel with this personal protective equipment as shown here. Therefore, the number of endoscopies and the throughput have been significantly curtailed. So if I can have the next image. So there's been a lot of interest in the UK in actually accelerating implementation of this Cytosponge test for use in this COVID-19 situation, because the nature of the procedure means that there's much less aerosol generated. There is still a small risk of aerosol just as you withdraw it, but that's just in the last few seconds. And really, it's very much easier in this kind of pandemic situation than endoscopy. So that's something else we can come back to perhaps in the questions. Next slide. So just to give you an idea of actually how this works. So you swallow the capsule, which will go into the top of the stomach, and the warm, moist environment will enable that capsule to dissolve. We allow 5 to 7 minutes to make sure it's fully dissolved and that sponge inside has expanded. And then as the nurse pulls it out, you'll collect some cells from the top of the stomach and then along the whole length of the esophagus. And in this animation, you can kind of see how clumps of cells are picked up and sort of trapped in this mesh, so that you get really quite a rich amount of cell material. On average, about 1 million cells are retrieved by this cytosponge, which is, as I say, just a 7-minute procedure. Next slide. So just to give you an example of, show you what the cells look like. So on the left, we have the endoscopic image of the precancerous condition, Barrett's esophagus. That's what the dark red appearance is. And if you take a biopsy of that, then what you find is that the cells have changed to this pre-malignant condition that the pathologist can identify. You can see the type of cell material you collect with the cytosponge, and the way that we process it, it's almost like a pseudo biopsy, so the pathologist can analyze it. But the cells that we're looking for are a very small proportion of the total cell material grabbed by the cytosponge. So what we do is to add a biomarker or an indicator to this cell specimen to make it much easier for the pathologist to spot. Next slide. So this is the test that we have developed for diagnosing the pre-cancer called Barrett's esophagus. And it's an antibody to a protein called trephine factor 3. And with this antibody assay, you'll see that the cells stain dark brown. And this basically just makes them very easy to spot. So in this big sea of cells here, which are white, that are normal, non-cancerous cells, the cells that suggest that the patient may be at risk of cancer are just highlighted there by this dark brown stain. Next slide. And one can potentially pick this up in an automated way using artificial intelligence assays for a rapid and affordable diagnosis to save the pathologist pouring down the microscope to spot these cells. Next image. So this is a very interesting area, and there's a lot of regulation around using artificial intelligence to completely replace what a pathologist would do, because you need someone accredited to sign out the case. But using artificial intelligence to help triage the cases so that the pathologist can then have their attention immediately focused on the cells of interest and screen out the ones negative from the positive cases and speed up the time of assessment is hugely useful. And so that's how we foresee artificial intelligence being used in the context of this test, is as a triage and to reduce the pathology time. And so you get this sort of digital image with a hotspot analysis, which color codes for you the areas of very low risk in blue to areas where the pathologist should have a look that are likely to contain the cells of interest, with this red background that I hope you can see on this image. Next slide. So, so we've developed this Cytosponge TFF3 test, and of course the next thing you have to do is to show whether it works in clinical trials. So we've done a series of clinical trials, and this was the first one, and the dates on this kind of portray how long this work has taken to go to concept through to proving it in a clinical setting. And this was a paper published in the BMJ in 2010, and this was a trial we did in primary care in East Anglia. So first of all, just ask the very basic question, would this test be acceptable to patients? We also did look at accuracy, but in this trial of 500 patients, the main concern was about feasibility and acceptability. And next image, please. The next trial was published in 2015 in a journal called PLOS Medicine. And in this trial, we took patients who we knew had Barrett's esophagus and compared that with our controls. So they were patients with heartburn who didn't have the condition, to see, really get a better idea of the accuracy of our TFF3 test to distinguish between the disease, the Barrett's esophagus, and the controls. And those trials went very well. Patients did seem to find it quite acceptable. It was quite feasible to do it in primary care. The accuracy data looked very promising. And so we proceeded on to our BEST3 trial, next slide please, which has just been completed and published just last week or the week before. So this was a randomized trial, and randomized evidence is sort of the gold standard for introducing a new diagnostic test. And for this trial, what we did was we took 13,000 patients around the UK in GP surgeries, and we divided them into two groups, half into the standard of care group. And what we meant by standard of care is these are patients requiring medication for heartburn, so they continue to get their medication, and the GP could refer them for an endoscopy if that was felt to be necessary. And the other half were randomized into being offered the Cytosponge. So the other half were all offered the Cytosponge. They still, of course, took their medication. They only then had an endoscopy if we found a positive Cytosponge result. So what did we find? Next slide. The main question we're asking is, do we find more cases of Barrett's esophagus if we offer the Cytosponge compared to usual care? And when you do these sort of trials, I was not privy to the results until all the analysis was completed. And the project manager asked me what I thought I expected to see, what I was hoping for. And I said that if we could detect 3 times as many cases of Barrett's with the Cytosponge compared to usual care, that would, I thought, be a good result. But here is what we actually found. So it was in fact 10 times more cases on the Cytosponge compared to usual care. So the absolute difference in rates was 18.3, and we convert that to a rate ratio. And for statisticians among you, we have to do some accounting for the design, which was a cluster randomized trial. But the bottom line for this is that the Cytosponge could detect 10 times more cases of Barrett's esophagus than usual care. Now, we were mainly looking for Barrett's. We hadn't designed this trial to look for early cancer, but the other question we were very interested in looking at as a secondary analysis was whether we did detect any cancers or precancers and whether they were earlier stage compared to those diagnosed in usual care. So the next slide, which is a little bit complicated, but just to take you through what we found here, this is looking at different stages of disease, starting with Barrett's at the top, low-grade and high-grade dysplasia, so that's precancerous states, early cancer, which is stage 1, and then later stages 2, 3, and 4. And on the far right-hand side, I've just written down what we do in these scenarios. So if we find Barrett's esophagus, they enter into a monitoring program. If we find dysplasia or early cancer, they're offered treatment down the endoscope or microsurgery. If it's later stage, then we're talking about chemotherapy or surgery, or if it's very late, unfortunately, palliative care. So of the 6,388 cases in usual care in the far column, we found 13 cases of Barrett's by the GP referring for an endoscopy. They found some cancer, 2 cases of cancer, which were treated with chemotherapy and surgery, and 1 unfortunately had already passed away by the 12-month follow-up period within the trial, and 1 patient with advanced disease for palliative care. Next slide. So the rest of the group were offered, the other half of the patients were offered the Cytosponge. Now, they didn't all take up the offer of Cytosponge. About 24% actually took up the offer. So first of all, let's consider those who were offered it but didn't have it. So some of those were detected with Barrett's. There was 1 patient who actually phoned us up interested in the trial, but before they could have the Cytosponge, they went off to have an endoscopy because they had some symptoms, and they had a stage 1 cancer, which was treated by endoscopy. And then there were 2 patients with advanced disease. And then we had the patients who were offered the Cytosponge and actually accepted it. Next slide. And here we see this large number of patients we diagnosed with Barrett's esophagus and some early cases of cancer. And to me, this is really a really important finding of this trial, that we could detect cancers earlier than we could in the other groups. And these patients all went on to have what's pretty straightforward treatment actually when you catch it early. So microsurgery down the endoscope, some we call it radiofrequency ablation, using heat energy to burn away the superficial layers. And these patients with an outpatient-based treatment could be cured of their disease. Next slide. And this is 1 patient who had an early cancer detected. who has been very keen to tell her story, which has been very helpful to us. So she's a retired scientist in Cambridge who was really curious about this technology, and so she took part in the trial. She had a positive result. You can see there the positive staining from her cytosponge. Next image, please. And when we had a look down the endoscope, she had Barrett's esophagus with a nasty big ulcer that turned out to be cancerous. This was shown on an ultrasound test. This is using an ultrasound probe down the esophagus to be early stage. Next slide. She had microsurgery down the endoscope to remove the areas. Next picture. And the pathology of the area removed showed that it was a very superficial cancer, and she was very fortunate because it was just at the point where it was starting to go deep. Next slide. And here is Liz, if we just start the video, that patient who...
Called the Cytosponge. You swallow the device and it helps to find something called Barrett's esophagus, which is a condition that can potentially develop into cancer. Liz is one of those lives it saved. She had no idea she was ill, but volunteered to try the device out of scientific curiosity.
I was just interested in the trial. I'd never heard of Barrett's esophagus, which is what this is looking for. And so I thought, yeah, I'd be interested in taking part. And I was very lucky, because if I hadn't, I wouldn't be sitting here now feeling perfectly healthy.
The idea is simple enough. Once in your stomach, the casing dissolves, leaving this wiry-looking sponge behind. After 7.5 minutes, the nurse pulls it back out and it scrapes millions of cells from the lining of your esophagus or food pipe.
So I just wanted to show you that because you get a sense of the whole procedure, but also I hope you noticed she was actually speaking to the cameraman while she had the string still down. So it's really quite well tolerated, and yeah, Liz has been a real advocate for this technology. Next slide. So I think the treatment is obviously very important for any early diagnostic test. You have to think, you know, if you find something, what are you going to do about it? And for esophageal cancer, it's very stark, the difference. So if we detect cancer when it's superficial, then we can treat it with endoscopic therapy as an outpatient day case with excellent survival figures. If it's more advanced, we're talking about chemotherapy and surgery, quite arduous treatment with a poor 5-year survival, less than 20%. And for our patients who are palliative, then it's symptom control, often doing something like putting in a stent to help them eat, but with very poor outcomes. So really, this is an example of a cancer where you completely transform the quality of life and what the patient has to go through, as well as their survival by early diagnosis. Next slide. So as I mentioned at the beginning, we have to think about the access to diagnostics as well as what the technology involves. You could just flick the other images onto the slide, please. And one thing we've thought about is you know, for the cytosponge, where it's best given. You can't really give it yourself at home. You do need something to do it for you, but GP surgeries are very busy, keep coping with the demands of, you know, symptomatic disease, and I think we need to think hard in our health services about how we unburden GPs with screening type procedures, and whether we could do it, for example, in the pharmacy. I just put these images up here for other sorts of technologies and the way people are thinking about it, where you might do self-testing or even have sensor technology which would alert you that you could be developing a cancer without you even have to go to the doctor. There are pros and cons to all these approaches. Be happy to discuss that with you, but I'm not sure how we'd all feel about the kind of big brother approach to our health, whether we want to be monitored all the time, but on the other hand, if you wait for symptoms, whether it's too late. So it's finding that sweet spot about what's really feasible, affordable, socially acceptable, and the ethics around it too, that are all important aspects of early detection. So it's not just about, you know, how far you can push the technology, but what's appropriate for society and what the sequelae of that would be. Next slide. So just to finish up, we're now thinking about, on the back of the results of this clinical trial, how we can talk to NICE and clinical commissioning about where we would position cytosponge technology in the clinical pathway. So in the primary care setting, we are keen on identifying patients on long-term medication for heartburn, often proton pump inhibitors or PPIs, and offering them a cytosponge in what would be a nurse or pharmacy-led clinic, and only endoscoping those who have a positive test, and being able to reassure the majority of them and even reduce the medication requirements, because a lot of these patients just get put on these medications for life. In the secondary care setting, if I have the next bit of the slide, we're also thinking about patients referred in by their GP to hospital for endoscopy, whether a number of those would be suitable, particularly if they've got heartburn symptoms, for a triage with a cytosponge to relieve some of the burden on endoscopy. And this might be especially relevant in our current COVID-19 situation, where there's a big bottleneck for endoscopy services. Next slide. Yeah, so it's just to say that this is aligned with commissioning priorities, and we have to think about the economics, of course, at all in this. And we know that increasingly our more precise drugs that target the molecular aspects of cancer are very expensive. So there's a question about, you know, whether precision cancer medicine is going to be affordable for the NHS, and if we start really moving more towards early detection, is that going to add more costs, or is it going to be cost saving? And the economics are quite complex around this. Of course, it will cost money to do a screening program, but then if we could diagnose cancer at an early stage, then we potentially reduce the costs of cancer treatment, and of course improve longevity, and the economics of that also then can be very favorable. So there are some estimates on the amount of the savings to the NHS from early diagnosis. This is CRUK statistics from a report in 2014. But I have to say the data really around these models are somewhat crude, and I think there's a lot more work to be done on really properly working through the early detection economics. Next slide. So I want to ensure that we've got time for questions, so I think I've really covered what I wanted to say. But just to mention that my thoughts in developing this particular technology, the Cytosponge, have been very much around what's practically feasible, and trying to be rather low-tech in terms of the device, but to couple it with lab tests, which I haven't talked in a lot of detail, but as well as the TFF3, we can add on other more molecular tests to really identify the people at higher versus low risk. And as from a global point of view, this sort of technology is very applicable in low resource settings as well, which is also something we're very interested in. Next slide. So thank you very much for listening. I'll be very happy to answer any questions. How long is a piece of string? I can tell you that this particular piece of string on Cytosponge is around 55 centimeters. Thank you very much.